wanted to talk about was really about the things which are prioritised and the things which are less prioritised in thinking about good healthcare. And I'm going to give a very short intro to this idea of healthcare quality, which I mentioned earlier, because I think for people who work in healthcare institutions or adjacent to them, that will be a very familiar idea, and for people who don't, it might be quite unfamiliar. So healthcare quality is in some ways kind of a way of talking about what is good healthcare. It's a way of thinking which came out of techniques of industrial quality control, so sort of Toyota production lines and things, and minimising statistical variation, minimising variation of products from sort of design schemas. And it was kind of adopted in a fairly widespread way in public sector services in like the 1990s, and continues to be very widely used as a way of thinking about how to measure how good public services are and to improve them. And in this way it's quite technicist, right? So it's that often when people talk about healthcare quality, even though it can seem like they're talking about what is good healthcare in a more general sense, and especially people who aren't familiar with the sort of more technical idea, the idea of what is the quality of healthcare can seem like it's sort of what's good about it. It can actually be quite technicist and about sort of closely defined, measurable improvements. And issues of design and aesthetics and architecture are really quite radically overlooked in healthcare quality and associated ideas like quality improvement, quality assurance, almost never discussed in research and I think in practice too. In general, there's a focus on sort of harder measures and outcomes like safety and clinical effectiveness and financial efficiency over softer measures and outcomes like well-being or satisfaction or relationships. And sort of within that kind of context, there's very, very little space given over to aesthetics or sort of spatial considerations. And in some ways, this kind of makes sense. Like as we've been talking about in maternity care, there's significant safety issues, big variation in clinical outcomes, including health inequalities, most notably relating to ethnicity, and there's also quite a lot of disagreement about best practice. So in that context, it's like, well, okay, fine, we deal with the big problems, and then we can deal with the small problems later. I think that's often how it's framed. So things like improving communication and being responsive to patient preferences and focus on comfort and well-being are sort of seen as nice-to-haves, or something which comes later, which is secondary to dealing with sort of like big clinical headlines. And sometimes these things are presented as being in opposition. So person-centred care is seen to be in tension with and as having to be traded off against clinical concerns, either because there's a competing use of resources, or more fundamentally because like patients want things or are perceived to want things that are of lower clinical value. And basically what I'm going to say in the next 5 minutes or so is that this kind of deprioritising some aspects of healthcare as relatively unimportant is problematic in various ways and is not a very helpful way of going about things. And in order to talk about that, I wanted to raise a slightly technical distinction, which is there's kind of two ways of thinking about improving healthcare, which we can call a logic of intervention and a logic of context. So logic of intervention is like when we're thinking about how to improve healthcare, we need to think about how specific interventions contribute to outcomes. So we need to define a specific pre-specified intervention and implement it and see what the consequences are for outcomes. And context is seen, if it's talked about at all in this context, is seen as a kind of barrier or facilitator to defined interventions. And then on the other hand, there's a more kind of contextual framing, which is looking at that context itself and seeing how features of different environments contribute to outcomes. And looking at it from that way, it's much more difficult to isolate specific contributing factors. But work in this latter area, this kind of more contextual work, can be more difficult to kind of evaluate because it's not picking out specific causal factors. So you get work you get research which ends up reasserting very well-known themes like leadership or culture or well-being or supportive environments without really giving that much specific detail about like what that means in practice or what should actually be done. So it can be seen as less useful for policy and practice. Whereas the sort of intervention logics can be seen as more useful because they give more definite sort of this works and this doesn't type sort of evaluations. But importantly, the kind of intervention logics can fail to appreciate the way that interventions and contexts are kind of co-constitutive of each other, and it's not ever possible to pick out an intervention separate from all of the kind of contextual factors which affect how it works and how it works differently in different contexts. So sorry, we'll get round to space and maternity issues in a second. So with that all as a kind of background, I wanted to think through just a few ways that sort of deprioritising as a whole certain aspects of healthcare or treating them as secondary can be problematic. So the first is, as I've kind of already indicated, that they can fail to reflect the way that different contributing factors interact to create conditions for good healthcare. You know, that the picture is causally complex. Things that seem relatively incidental to clinical care can actually have a big impact on orthodox safety and effectiveness concerns. So I was just talking to Ben about this brilliant ethnography of Southmead Hospital maternity unit, which is like the highest performing maternity unit in the UK. And in this ethnography it describes them having a multidisciplinary breakout room, which, you know, might be kind of seem like it's just kind of, you know, they had room for one breakout room, so, you know, so like one staff room, so everyone's in there together. But actually it has like fairly significant implications for the way that different staff interact, allows them to develop relationships of friendship and trust, to understand each other's characters in ways which are really supportive of the safety of their unit. And similarly, you know, if patients or expectant or birthing mothers feel safe and relaxed in birthing rooms, they may feel able and are able to make it their own space and make decisions about it and sort of have some sense of control over the situation or command. That has the potential to impact on their ability to communicate well, to respond to their bodily needs, and that can impact on things like the length of labour and complications and need for interventions and stuff like that. So you have these kinds of connections between things which might seem like a bit fluffy or a bit secondary and things which seem very primary on anyone's terms. And the forces that create these positive conditions for, you know, safe and effective care can be relatively hidden. They can be sort of tacit and invisible because they're habituated and not really seen as things that are actively done. You know, they're seen as background factors, and I think that can be particularly true of things relating to space and architecture because they're not easily changed and they're not things that can easily be experimented with. So all that is sort of instrumental reasons for valuing these things, right? We value things like space and aesthetics because they lead to other things that we value. But I think it's useful not to just think of them in purely instrumental terms because, and as has already been discussed by other people today, seemingly kind of shallow or small aesthetic considerations or preferences can have really deep personal and social meanings and associations which make them, you know, ethically salient in their own right. They're things which we should attend to not just because of the other kinds of clinical benefits that they bring. So, you know, if the material and social conditions of a maternity unit makes patients feel alienated or powerless or afraid, especially at a time of like huge personal significance and transformation, that's in itself something to be avoided, even if it doesn't have like some bad outcomes, you know, on someone else's account. And similarly, if material conditions which help to create a workforce that's characterised by trust and care and support and which gives staff well-being, like that's a good thing in its own right, regardless of the impact on the people who they're caring for. So I guess this is all I'm going to say, and I guess the sort of key thing here is that it's those things, those kinds of non-instrumental reasons for valuing these things are intimately connected to the instrumental reasons, because they're so significant to people that they have implications for clinical practice and safety and so on, because they have such a huge impact on people's sense of self, sense of identity, on their behaviours, on their attitudes, on their psychological states, and so on. And so sort of trying to separate out the instrumental from the non-instrumental reasons for valuing those things actually is maybe not a very helpful thing to do, because it fails to capture the way that they connect together and sort of influence each other. So that's all.